I think we are on time now. Let's so let me give a brief, a little bit brief about this case. Tommy, how old is the child again? It's I think he's a few years old, right? Tommy, do we have the precise age?
According to the lab reports, this patient is born in 2012.
Yeah, should be 8 years old.
So
8 years old. Oh,
yeah.
okay. Yeah, 8-9 years old, and he has autistic symptom. We have screened him to be positive with autistic spectrum disorder. In fact, more towards the severe side, isn't it, Tommy? Yeah.
Yeah.
So
more severe side.
right.
And what medication is this patient on?
Can everyone else mute themselves? We have when we did the test, he was not on any, right, Tommy?
No, the time he doesn't take any medication.
Yeah. So now we have prescribed some supplements only. He's taking a number of supplements, but that would not affect the test results that what we are having so far. All right. Yeah. So
currently he's not on any medication, is that correct?
Only some nutraceuticals.
Nutrient supplements, okay. Not any prescription medicines?
No,
okay.
no.
All right.
Right.
Yeah.
Yes. Right.
So is there a family history of this particular condition in their family?
Tommy, I don't think any brother or sisters have that. Not that we have.
Not that we have
detected.
that.
Yeah. Yeah.
Okay.
Right. And yeah. Anything else you want to know about the background?
Is the child developmentally, he's got ADD, yes, but physically is he developed as a
it's more ASD.
ASD, yes, and
ASD,
so
yeah.
and is he developed physically normal activity, or what does he present with as far as his ASD symptoms are concerned?
I think speech is a major issue.
Yes.
Tommy. How about coordination, Tommy? It seems to be well coordinated.
Yeah, well coordinated. Is the speech.
Any hyperactivity?
No.
No. Right. Focus.
Focus a little bit.
Yeah, could be some attention issues there. How about writing, drawing, or that motor skills?
Not much issue.
Not much issue there also. Yeah, but social interaction definitely a big issue. Yeah.
Yeah.
Okay.
Yeah.
And is his diet relatively healthy? Is he eating a wholesome diet?
Not initially when we did the test. So we have advised the family to.
Okay. So shall we go ahead and have a look at his results?
Yes, please do.
Yeah. Okay. So I'll share the screen.
Yeah.
And and just let me know if you can see his results. Can you see his results?
Yep.
Yeah. Okay. So the first result we have available is his methylation report. And the reason why you would look at methylation is because the underlying neurotransmission pathways is actually driven by methylation. These are methyl groups, which is basically a carbon and 3 hydrogens that are just basically transferred and accepted across many reactions, physiological reactions in the body. So when we see his results, we actually look at a number of avenues. So what we're doing is we're seeing his results now, and he's heterozygous for the C677T gene. This molecule, methylene tetrahydrofolate reductase, is in actual fact an enzyme function that is involved involved in which is dependent totally on folinic acid. So when the most dangerous form of methylation defect is homozygous for that C677T gene, and then after that it'll be compound heterozygous, and then heterozygous for the C gene. So he's lost about 40 to 50% of his methylation capacity. To correct this, we need to actually give him methylated versions of folic acid to actually help him along, okay? So you can use methylfolinic acid or 5-MTHF. These are the various strategies to actually help that particular pathway. As far as the methionine synthase pathway, that is from homocysteine to methionine conversion. There is no mutation found. So that's a good thing when there are no mutations found. That means that pathway is actually working. The next avenue is MTRR, which is methionine synthase reductase, and that's one from 5-MTHF through the same pathway with homocysteine, and it goes into the folate, feeds into the folate pathway. Again, no mutation is found. So that's a good sign that that particular pathway, which is usually driven by vitamin B6, B12, betaine, tetrahydrofolate, particularly your zinc as well, zinc B2, B6. So that particular pathway is working. AHCY is a pathway that actually works from SAR to, so S-adenosyl homocysteine into homocysteine. And this is usually driven by vitamin B3. There is no mutation found there as well. And COMT, of course, so many avenues of enzymatic function, including estrogens and including your catecholamines, are actually driven by COMT. So no mutation is found there. So overall report on his methylation genetics is really, he's got one major issue here, and that is he is heterozygous for the MTHFR C677T gene. So the clear pathway here is to actually drive the folate pathway in a better way. So give him more folate-containing foods, a lot of the spinach and the kale and the greens, a lot of the Asian greens, they all rich in folic acid. And that needs to be given to this child in conjunction with methylfolate.
And how many mg of methylfolate would you say, since 40% is compromised?
I think it's from memory between 1 and 5 milligram would be considered to be adequate, but I stand to be corrected.
Sure.
So in relation to his FIFA profile, so you do the FIFA profile, particularly with ADD, ADHD kids, behavioral issues, and especially if you're suspecting nutrient imbalances. The level of zinc and copper, this is work done by Dr. Cole Pfeiffer, Dr. Bill Walsh, on the use of these very nutrients that will actually drive a particular pathway towards or away from methylation. And it also reveals a lot of information about a patient. So vitamin D, ideally you want vitamin D to be up to 150, and this child's vitamin D is 49. Now we know vitamin D is needed for calcium uptake, etc. But vitamin D is also needed for adrenal function, and we need good adrenals to make ceruloplasmin, which is the plasma protein that carries copper. So vitamin D and vitamin A are very, very important for ceruloplasmin and adrenal function. So homocysteine here is low. So homocysteine basically means that the homocysteine is not converting. Usually when it's high, a bit above 8 and onwards, we suspect inflammation, but when it's low, the capacity for the body to produce energy is impaired. In other words, the transsulfuration pathway, the CBS pathway, is not working effectively. And these are people that actually need, glutathione, N-acetylcysteine, etc., to actually help stimulate that pathway. Now we can see his copper is high, right? His ceruloplasmin is within normal range, but because ceruloplasmin is the taxi that carts the copper around in the body, ceruloplasmin is in actual fact carrying copper to the various tissues. Ceruloplasmin is normal. It can be optimized somewhat with good adrenals and with good vitamin D, but that ceruloplasmin that taxi can only carry that much copper. So the amount of copper that is not carried in with ceruloplasmin becomes oxidized. And oxidized copper is almost as dangerous as mercury in the body, particularly in the brain of an ADD, ASD child. So we've got to drive down that elevated copper. The free copper is so high. So what is the picture when you see high copper? High copper, you will usually see they are over methylated, right? We know that this patient needs folinic acid, but you do not throw methyl cofactors at this child because they are over methylated. You've got to clear that excess copper. They tend to have low histamine. So let's have a look at his high copper, low histamine, over methylation. That's a simple formula. So let's have a look at his histamine. His histamine is low, okay? So he will have digestive incapacities, right? Because histidine is needed for digestive capacity, right? So let's have a look at that copper. When that copper is high, we will see low histidine, which we've already established. And these are usually people that tend to be slow metabolizers, slow oxidizers. Because they are over methylators, they tend to favor vegetarianism as opposed to eating meat, because they probably have, they're over methylators, they don't need meat, right? They tend to have, in adults particularly, they tend to have low cortisol. And low cortisol is like burnt out. Some people who have high copper also tend to have the Th1 or Th2 dominance. So that's stress and bacterial infections, etc. So what do we do to actually drive down that excess copper? There are many strategies that you can do. One is we need to make sure that we're giving them vitamin C, vitamin D, vitamin A. We've got to make sure that they've got enough molybdenum, because molybdenum is needed for neurotransmission pathway as well as the transsulfuration pathways. Magnesium, manganese, vitamin C. And amongst the amino acids, we definitely need to give him histidine, because histidine is a precursor to histamine. Secondly, we need to use taurine, glutamine, because they tend to be anxious. Glutamine is a precursor to GABA. Threonine, cysteine, because we already now know that homocysteine is low, so we've got to stimulate that transsulfuration pathway with N-acetylcysteine or cysteine. And we also need to check their iodine levels, okay? In a child, not so much. In an elder, you definitely got to check iodine levels because they slow metabolizers. You'll tend to see hypothyroidism in these sorts of people with high copper, low histamine. Let's move on. We can also see that they've got SAMI is fine, but SAR is low. So here we mean that SAMI converts to SAR and then SAR feeds into homocysteine. And we know that homocysteine was low. So what feeds SAR to homocysteine is vitamin B3. So we need to incorporate niacin, niacinamide, etc. We also need to ensure that we've got enough glycine. Now remember, glycine is an inhibitory neurotransmitter that actually feeds into the GABA pathway. So it feeds into their anxiety. So we got to ensure that the GABA is restored, right? Let's move on. We can see that the histamine, we've discussed histamine, that's low. The zinc is within normal range, but low normal. So therefore, the copper to zinc ratio will be high because copper was super high. So we might need to give this patient some zinc in line with all those other strategies we mentioned. Okay. And I think that's the end of that pathway. So really, this is the cystathine. We need to push up homocysteine, and we do that by improving the CBS pathway. We need to incorporate cysteine and cystathine and cystine. We also need to make sure that vitamin B3 and glycine is incorporated into to ensure that we have, SAMI was fine, SAR was low, so we need to ensure that that's fine. The methionine was fine because MTR and MTRR pathways there were no mutations found. The mutation that we actually found was in your MTHFR. So we definitely need B2, B3, as well as methylated folinic acid. All right.
Yes.
What else? That was the end of that one. Let's move on. So now we'll go into the neurotransmitters for this child. Now, when we're looking at, sorry, anybody has a question? Okay, let's move on. So when we're looking at neurotransmitters, with a child who is under 11 years old, you do not use this adult optimal range. That is for 11 years and over. So do not use that range. We actually use the range that we have already in existence. So here we can see that firstly, always look at inhibitory pathways first. So we can see that the serotonin is super low. So this child is depressed. It's got low serotonin, right? And the GABA is within normal range. So this person does not have as much anxiety as it has depression. We also know that the glycine, which is a precursor to GABA, is sufficient. The glycine is quite sufficient. So therefore, I would suggest that we focus predominantly on the serotonergic pathway. Now, how do we?
But Vanita, from the previous report, you were saying that he might need some glycine, but from here it seems that he's fine. So that means glycine
that's
is
fine. So from the
needed.
Previous report, we mentioned that glycine is one of the cofactors that are required. So if you have a look at this, SAR was low, his glycine is sufficient, but homocysteine was low, so therefore vitamin B3 is most important, not so much glycine. We definitely need to give him vitamin B3. All right.
Fantastic. Thank you.
And so, and we see that glutamate is on the low side as well. So if glutamine is the precursor to glutamate, glutamine is needed for the immune integrity of the gut. So while serotonin and GABA are made in the mucosal membranes within the gut, and if the serotonin is low, we need to inquire, is the gut optimized? So we might need to give him prebiotics that contain glutamine and probiotics to restore that gastrointestinal immune diversity within the gut. And if we're able to do that,
probably we would recommend doing like a leaky gut test or a stool test to
I would probably suggest that you do a complete microbiome map for this child for one reason, and that is because it incorporates all those inflammatory markers as well as the microbiology. So it'll give you an indication whether this patient has leaky gut or whether they have poor immune integrity or whether they have an infection in the system. We know that conditions like neuropsychological disorders such as PANS and PANDAS are associated with an infection, predominantly streptococcus. So, you know, we want to rule out any of those infections that are happening within the gut, purely because the inhibitory neurotransmitters are predominantly made in the gut. Okay, sure. So we definitely want to give glutamine. Now we can see that the histamine in a neurotransmitter test is sufficient, but we still want to incorporate histidine. Now, phenylethylamine, let's talk about phenylethylamine.
But Vanita, so from the previous report, histamine was reported as low, but here it is adequate. How do we reconcile
so one of the things that we looked at is histamine in a blood test. Yes. A whole blood histamine level was low, right? Yes. In a urine test, his histamine is adequate. So in the case of histamine, there are histamine receptors everywhere. There are 4 types of histamine receptors. They are found in your mast cells, and that's in the blood. They are found in the gastrointestinal mucosa, and that is in the blood. They are found in the neurotransmission pathways, and they are reflective predominantly in the blood. We can't discard the fact that the urinary excretory metabolite of histamine is sufficient, but the blood levels of histamine is low. So the blood levels would carry a lot more weight in terms of histamine in this regard.
Right.
Now, one of the things that phenylethylamine is high and dopamine is low. So let's just have a look at this. Let me write that down. Phenylethylamine is high, dopamine was low, noradrenaline is within normal range, and adrenaline is within normal range. So his adrenals are working effectively. So let's have a look at a pathway. When we have a look at his pathways, we can see that phenylalanine and tyrosine are the amino acids that actually make dopamine, and his dopamine was low, right? What is it that is required to make dopamine? We need tetrahydrobiopterin, we need iron, and we need vitamin B6 together with phenylalanine and tyrosine to make dopamine. In the absence of iron, particularly, the phenylethylamine or phenylalanine will convert to phenylethylamine. And phenylethylamine is one of the major areas. This is high, right? Phenylethylamine is high, and this is a marker of ADD and ADHD. Okay, this is actually a predictive marker. If that is elevated in light of a low dopamine, then we definitely need to ensure that we are either clearing this pathway effectively. So the patient has enough copper, but they might have insufficient B2 or insufficient SAMe in order. And SAMe is needed for serotonin production as well. So we might need to incorporate those cofactors to clear that PEA, but we've got to drive up the dopamine. How do we do that? We can use mucuna, we can use tyrosine, phenylalanine, and iron. Iron is often the best, one of the major cofactors. You obviously need to look at all those other cofactors. So this high PEA is associated with ADD, ADHD, ASD disorders or behavioral disorders, as well as low dopamine is associated with low motivation, low satisfaction, addictions towards certain activities or behaviors, or addictions to a thing like doing something, washing hands, eating something, yes, for example, okay? Like alcohol addiction is a dopamine deficiency. And you will often find kids that are ASD, ADD, they tend to have impaired cognition, one, because they're slow learners, or they could be super smart in one area only. They could be amazing musicians, but they cannot speak socially. And this is when you see that high PEA, low dopamine level. So we definitely need to drive up the dopamine and clear that PEA in order for this pathway to work effectively. All right. Make sure, once again, your dopamine is low. So you need to feed that dopamine. And you can actually stimulate each of these pathways. And we did see his noradrenaline and adrenaline within normal range. So his adrenals were fine. Why do we know that? Because ceruloplasmin was within normal range. So this is the reason why we need to drive up that dopamine. Let's go back. So we've discussed PEA and dopamine, noradrenaline and adrenaline, and then you're looking at the ratios. So now we can see that noradrenaline to adrenaline ratio is low. That means noradrenaline is low relative to adrenaline. Nothing much to worry about. However, if it was the opposite way, then we know that there's methylation defects. All right. And I think we've covered, okay, so now let's have a look at, remember we said that your serotonin was really low. Now serotonin, once it's used up in the body, is converted into 5-hydroxyindole acetic acid. This particular metabolite of serotonin is low. We know that the serotonin was low and the 5-hydroxyindole acetic acid is low, right? Therefore, we need to find out what's making serotonin. We might need iron, we might need your tryptophan, 5-hydroxytryptophan, B6, as well as SAMe to ensure that we're feeding into the serotonergic pathway.
Right.
Make sense?
Yes.
All right.
Makes sense. Yeah.
Okay, so put things into summary. We definitely need to give this patient folinic acid. Next thing, we've got to clear that excess copper. And as we mentioned, all those cofactors, vitamin C, your amino acids such as taurine, glutamine, histidine, threonine, cysteine, all of those amino acids, vitamin D, vitamin A, vitamin C, zinc, molybdenum, manganese. These are all the strategies that will actually clear excess copper. We might want to give the patient some glutathione or stimulate that homocysteine to glutathione conversion, and we do that with N-acetylcysteine. We must give the patient vitamin B3 to ensure that AHCY as well as your CBS pathway is working. And finally, we need to ensure that we focusing predominantly on the serotonergic pathway, clearing PEA and pushing dopamine up. Those are the major areas.
Fantastic.
Any questions?
Well, I would just say that you know, it shows how important it is to have a multiple lab tests, right? Not just the neurotransmitters, but you know, combine it with the fiber and even the methylation, the detox test to reveal a more accurate picture. Like for example, the histamine was found to be adequate in the neurotransmitters test, but on the blood test, it was actually low. So that is very revealing.
I totally agree with you, Dr. Chan. When you're looking into mental health, particularly in ASD, autism spectrum, ADD, ADHD, or any behavioral issues, looking at neurotransmitters is absolutely essential, but you always need to look at the drivers. If the drivers, you mentioned the first thing, this child is not eating adequately. So you need to actually ensure that this patient is eating those folic acid rich foods. And they also putting those amino acids, the proteins that feed into those amino acids to correct the system. The other thing that we've neglected very importantly with children who have impaired gastrointestinal microbiota, identify their complete microbiome map. And that will identify, you know, bacterial, fungal, virus, and parasitic infections, as well as the inflammatory markers. But now what happens if, let's say, this child has developed this condition because of occupational history of the parent? For example, the parent might be a dental technician or or working in the mines, or, you know, they might be exposed to heavy metal loads. In that instance, you would need to ensure that you're identifying the heavy metal toxicities as well.
Yeah, so doing a hair test might be useful.
You can do a hair test. It's a really broad spectrum test, which is very effective. And the reason it is effective is because it covers so much, all your minerals as well as the metals. Be very useful to identify these imbalances. So always when you're looking at mental health, particularly in the elderly or in adults, you'll often find that identifying the neurotransmitters is paramount, but often what causes it, when did you feel so depressed? Is it because of menopause, or because of a divorce, or because of a major trauma or stresses? That's when you look at these drivers. So the drivers in that instance would be your adrenal cortex stress profile together with neurotransmitters. If there's a family history of mental health, you might want to look at their pyrols. Or if there's a lot of inflammation as well as mental health, you might want to look at the methylation factors. So this is, and then also food intolerances with kids particularly. You know, you might find that this child might be eating foods that he's intolerant to, and that's developing this whole cytokine storm in the body. And young kids, they're quite resilient, but you put the same scenario in an older child or an adult, they find that they have major allergies. So definitely incorporate those strategies.
In this patient's case, given that his adrenaline and noradrenaline are quite okay, right? Would it be useful to do a hormone test, like a cortisol awakening response, which we haven't done? So that would
there's no need for you to do that.
Yes.
I would look at all the drivers that pertains to this child. This child as an ASD, is the food right? In other words, does he have food intolerances? What's happening to the gut microbiome? Look at the family history and determine, is there a exposure that we're overlooking? But as far as cortisol is concerned, I wouldn't worry about that, because it's adrenaline, noradrenaline within normal range.
Very good. Yes. Anyone else have any question for Vanita, Tommy? All clear?
Please unmute yourself if you have any questions.
A lot of very good information. Fantastic. Yeah. Would mold be a possible concern, you think, Vanita?
Unless in your patient intake you have identified that this child is living in a moldy environment, then it could be a concern. Or if the child has respiratory distress or sinusitis, rhinitis, etc., then you may want to, or allergic responses, mast cell activation syndrome, all those symptoms associated with it, then yes, I would definitely look into it. But based on these numbers there, it probably would, but again, based on patient intake, you'll need to make that determination.
Yeah, but definitely do an IgG test, and then we can see whether that's
especially that, as well as the gut microbiome as well.
Right. Fantastic. Yeah, we do have an IgG inhalant test, and that can be done and see whether there's any issue there. Right. Yeah. Fantastic. Good. Yeah.
Anybody got any questions? Or everybody's happy?
Right. We do have. Yeah.
Okay. So are we done, Dr. Chen?
Yep. If there's no more questions, we're done. Vanita, fantastic tour of based on this reports, and we thank you so much for your time.
Thank you. Okay.
Good night.
Leave you to
it.
You too. Thanks. Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.